We will now discuss the peripheral connective tissue. When we perform a cast corrosion study of the tracheobronchial tree and of the pulmonary vasculature, we dissolve all the connective tissue of the. Likewise, if we study the peripheral portion of the airway, the alveolar sacs and alveoli, we only see the inside of these structures. The walls have been digested. The smallest anatomical unit that can be radiographically visualized are the acini and the secondary pulmonary lobule of the lung. The latter is a unit of lung structure 1 to 3 centimeters in diameter, separated from other lobules by interlobular septa. Lobules are irregularly polyhedral in shape and randomly arranged one to another. The acinus is a unit of lung structure representing a terminal bronchiole and the lung subtended from it. The acini are 5 to 7 millimeters in diameter, and there are 3 to 5 acini per secondary lobule of the lung. The bronchioles that lead to the secondary lobule of the lung are the terminal, and from there the respiratory bronchioles arise. The difference is that the latter have alveoli in their walls. There are about 28,000 terminal bronchioles with a mean diameter of 0.6 millimeter and about 225,000 respiratory bronchioles with a diameter about 0.4 millimeters. It must be remembered that beyond the acinus is the primary lobule of the lung, where gas exchange takes place, but this is not a radiographically visible. A secondary lobule of the lung has a core and septa. The components of the core are the terminal branches of the pulmonary artery and the terminal branches of the airway. And obstruction of a pulmonary artery may lead to an infarct. Disease of the airway can result from pneumonia, bronchioloectasia, and also emphysema. When we look at the septa of the secondary lobule, we note that they contain the beginning of the pulmonary venous system, lymphatics, and also have connective tissue. Disease of the pulmonary veins, particularly when increased pressure has occurred either permanently or temporarily, will lead to interstitial pulmonary edema. Likewise, obstruction to the flow of lymph from the lung towards the hilus will result in interstitial pulmonary edema. Obstruction of lymphatics can also be the result of a tumor spreading from the lung towards the hila. And lymphangitic spread of cancer is a cause of abnormal lymphatics in the interlobular septa. Diseases of the connective tissue of the lung will lead to interstitial pulmonary fibrosis. This is a close-up of a formalin-fixed lung specimen where we can see polyhedral structures that represent the pulmonary secondary lobule. The reason that we see the walls of the secondary lobule is because they are impregnated either with hemocysteine-laden macrophages. This is seen particularly with chronic congestive heart failure or with amphotic pigment. In this close-up of the right lower lobe, we can see distinctly thickened interlobular septa, which appear reddish, and they had histologically hemocysteine-laden macrophages, and there was increase in the connective tissue and edema as well. This patient died with chronic congestive heart failure. This is a photograph of the diaphragmatic surface of the lung of the previous patient, and one can see the intense impregnation of the connective tissue of the walls of the secondary lobules, and the increase in reddish color due to hypostatic congestion, chronic congestion from heart failure. This is a specimen to your left and a radiograph of the specimen to your right, indicating with the arrows the walls of the pulmonary secondary lobule. When thickened, they form what has been described as the septal lines or the curly B lines. Here is an axial view of the peripheral lung. We can see central structures that represent the bronchioles and pulmonary arterioles, and you can see the thickened walls of the interlobular septa. And note that we see quite distinctly terminal bronchioles within the boundaries of the connective tissue that surrounds the pulmonary secondary lobule. My good friend David Trapnell from London gave me these slides after he injected contrast material into peripheral lymphatics. The radiograph shows the direction of lymph flow towards the center of the lung, and note the marked thinness of the peripheral lymphatics of the lung. Note another injection of the lymphatics and observe that some follow the pulmonary veins. They reside in the walls of the secondary lobule within the connective tissue that exists at that level. At one time, the peripheral lines that ran perpendicular to the surface of the lung were interpreted as possibly representing enlarged lymphatics. We have seen, as well as others, that the caliber of the pulmonary lymphatics are so small that they are radiographically invisible, even if they are distended. This is a close-up of a thickened wall of a pulmonary secondary lobule, which contains dilated lymphatics within it. It is the thickened wall that accounts for the septal lines, not distended lymphatics or distended venules. Another axiomatic rule is that pulmonary lymphatics are not radiographically visible.